Hi, pod people. This is Mike on the mic, Mike Sokolowski. I am thrilled to be joined today by Damon Terzaghi. Uh, we are going to talk very exciting stuff, Medicaid. I know this is things that all people getting into home care really want to dive deep into, but I will say this. Uh, it is on top of everyone's mind, especially in the last year. Ripple effects of legislation and things that are happening in the states as a result. So we have an expert today to talk to you and discuss what these changes look like, what happened, and get into some of the details. So Damon, we'll jump right in. Let's talk seismic. Let's go right in to earthquake type stuff. What is the most noticeable change to home care and the industry in general because of this estimated 900 billion in Medicaid cuts over the next decade?
There's going to be a lot of changes, I anticipate. I think it's important to kind of start at the beginning, though. When you look at the law and you look at a lot of the statements that were made during the debate around that legislation, there's an explicit attempt to try and shield older adults and people with disabilities, and by virtue of that, home care, from many of the starkest reductions. It really is targeted to that Affordable Care Act expansion. And when you look through the different legislative provisions, it's pretty evident where they were focusing their efforts and their fire. With that said, you can't cut that much money out of the Medicaid program without impacting this population and these services. I mean, frankly speaking, younger adults, moms and kids, the expansion population, that's not where the money is. The money really is focused in older adults, people with disabilities, long-term care services, just by virtue of the type of care we're talking about and the cost of delivering these types of services. So what do I anticipate happening? I anticipate a few things. First of all, when states look at their overall Medicaid appropriations, they're not going to focus all the cuts in one area. There's just no way that any state, both from a political as well as from an operational perspective, could say, oh, well, these cuts really came in focused on our hospital side of financing, so we're going to funnel all the reductions to the hospital industry. They just can't do that. So I anticipate a real challenging fiscal environment for all Medicaid providers, for all people who care about Medicaid. And I think that it's going to play out in a bunch of different ways across the country, depending upon which state you're looking at. This can include things like a reduction in the amount paid for services, the provider rates, the number of services authorized for individuals. You could see harder caps on the number of hours individuals are provided. Service eliminations. There are certain services in Medicaid that are optional. A little bit less on some of the home care stuff. I don't think we're going to see full eliminations. I think we're probably going to see more caps on services in home care than full elimination. But things like optional benefits, adult dental is a big one that we see cut in times like this. And I think that we'll see states looking at that again. So those are the types of things we're really talking about from a service perspective. From a eligibility perspective, the big one is waiting lists. Waiting lists have been a problem for decades in home care and Medicaid around the country. There's still, I think, 700,000 estimated people on waiting lists around the country. I don't think that number is going to go down, especially in light of what we're talking about with these forthcoming reductions.
We looked at the financial impact and how they'll affect services. There's also mandates tied to a lot of this. And one of them, if I'm reading it correct, says 80 hours per month of community engagement for able-bodied adults. So how might that requirement affect continuity of home care services for those Medicaid recipients?
There's a couple ways to think about this. The law, as I said earlier, tried to exclude people with disabilities from some of the impacts. However, there's not a really clean way of identifying who has a disability when you're looking at Medicaid and how people become eligible. People with all sorts of different financial, social, economic, and disability statuses enter through a variety of different eligibility groups, is what we call them. So that Affordable Care Act expansion that I mentioned earlier as being the target for a lot of the cuts actually covers a lot of people with chronic conditions, with disabilities, with other sorts of medical or functional limitations that may require home care services. So there is an issue with continuity of care related to this. Demonstrating that you're exempt from these requirements is going to be a big and important lift for individuals in Medicaid who receive home care services. It's going to be challenging. And I actually anticipate they're going to be really relying on us in the home care industry to help them navigate these new requirements. We talk about administrative burdens, we talk about red tapes. This is going to be a big one. If you followed Medicaid over the past couple of years, there was a big initiative at the end of the COVID-19 pandemic wherein individuals had been kept on the Medicaid program indefinitely without what we call a redetermination in order to ensure continuity of care during that crisis. When that extended continuous eligibility period ended, states had to go through and verify who should be on the program, who shouldn't be on the program. One of the big takeaways from that was that even people who should have remained on the program were disenrolled because of administrative processes, not because they weren't eligible, but because the paperwork burden was significant. They didn't understand what the state was asking of them. They didn't realize the deadlines or the timelines or the requirements. And that's a big thing we're looking at for the work requirements and the risks associated with that. We actually talked to CMS last month about some of the concerns and some strategies and recommendations to ensure that individuals receiving home care aren't caught up in some of these, what we call administrative disenrollments.
Burdens, hurdles.
Hurdles.
Teeing me right up. So these, potential hurdles, administrative burdens that are placed. We do a lot of advocacy. You do at the Alliance a lot of advocacy based around a lot of these administrative hurdles that literally prevent us from providing home care. So what, enforcing these standards, like what impact would that have on participation rates? Where do you see participation rates going because of all this?
I definitely see a decline. I think that there's no way to look at the new requirements and expect that every single person is going to be maintained in the program and that no one's going to fall through the cracks. The really important thing is, I think, for the federal government to have very clear and strong expectations of states around these exempted populations. Anyone who has a claim for home care on their record should be automatically exempted from the community engagement requirements and should no longer have to verify in the future. There's what we call the medically frail exemption built into the law. If you require home care services, you should qualify for that exemption indefinitely. That is just a very clear ask, and I think CMS needs to put out clear guidance to that effect and expect states to follow it. We shared that with CMS during our conversations, and they seemed receptive to it. Another thing is, one part of the law that I think sometimes goes under the radar is it doesn't require people to enroll in Medicaid and then meet this 80-hour a month requirement, the 80-hour a month requirement is a condition of eligibility. And what I mean by that is the law says that individuals have to demonstrate it for the month prior to Medicaid enrollment. So you have to meet these requirements in order to even enroll in the program. It's not, enroll in Medicaid and then have to meet the community engagement requirements. And I bring this up for a couple of reasons. First of all, I don't think most people know that. And I don't think most people walking through the door to a Medicaid eligibility office are going to be thinking about that kind of thing. Take a step back. Who are we talking about when we're talking about individuals who are seeking assistance through the Medicaid program? These are individuals who are in a crisis most of the time, who are in a very, very challenging part of their lives. I don't think they're going to have this community engagement requirement at top of mind. So they're going to walk through the door and be told, oh, I'm sorry, you have to go out and have 80 hours a week of work or of volunteering community service or of education and then come back to us. And it's going to be a pretty significant barrier to care, I think. For our population, again, they should be exempt from these requirements. But if you're an individual that's walking through the door, potentially in need of home care, you don't meet these requirements. How do you demonstrate that you're exempt? You might need a doctor's note or some kind of medical care to show the state that you're exempt. But if you're applying for Medicaid, that indicates you need medical care. So how are you supposed to get that type of documentation in order to qualify for Medicaid? It's a really big conundrum. And again, these are the types of issues that states are going to have to sort through and come up with clean and clear policy to help ensure that individuals who require in-home supports are not unfairly and inappropriately locked out of the system.
Last 15 years, specifically in home care for me and the advocacy I see, we literally go to state capitals, we go to Capitol in DC, depending on the type of advocacy we're doing, and there's no hiding it. The ask is always you need rate increases to these programs to keep up with cost of living, to pay better, to grow the workforce. Now, I started this conversation with the 900 billion-ish number, that little number. So as Medicaid provider payments are capped, how likely is it that home care agencies are going to see reimbursement? I don't want to say this, reductions.
And I think that it's a very real risk moving into 2026 and beyond. I think, at the time that we're recording this, it's early January of 2026. A lot of the legislative sessions haven't started yet, but they're beginning. And the various policymakers are looking through the funding allocations, looking through the federal reductions that are coming from this law. And I think there's a lot of consternation around the country, not just from us in the provider community, in the beneficiary advocacy community, and amongst state house lawmakers around how these programs are going to be funded moving forward. I think that 2026, 2027 are going to be very, very hard years fiscally for states as they begin to parse through the real fiscal impacts of this law and how to respond to it. I keep harping on this issue of older adults, people with disabilities, long-term care services were supposed to be excluded from the law, but there's no way to cut $900 billion out of Medicaid over 10 years without impacting those individuals and those services. The way that Medicaid programs think about this and talk about this, drawing from my experience, having worked both in a Medicaid agency as well as at CMS, is that there's really only three core ways you can control budgets in the Medicaid program. You can cut the amount you pay for services, you can cut the number or the amount of services you provide, or you can cut the number of people receiving services. That's kind of it. And so, as I mentioned earlier, I don't think states are going to concentrate all their reductions on any one of those three areas. I think you're going to see them spread across. And so that will mean more stringent eligibility for participants, fewer services, more limits on the amount, duration, of scope of care that's allowable, and limits on provider payments, whether that's just keeping them flat and not adjusting for inflation, or as we've started to see around the country already, cuts to the amount paid. I'll give you a couple of specific examples. Idaho has already come out with a 4% across the board reduction to every Medicaid covered service. Not targeted to hospitals, not targeted anywhere, just every Medicaid service cut by 4%. Colorado has rolled out a whole wide range of reductions to their programs, including their long-term living programs, as they call them. And there are rate cuts associated with that. I don't know that I have to tell a lot of the audience about the dynamics in North Carolina. I'm sure many of you are intricately familiar with the debacle that's occurred there over the past several months. That's not just because of HR 1, but HR 1's definitely playing a role in the broader fiscal challenges that that state is wrestling with the massive cuts, the restoration, and now the future uncertainty. If they were already coming out with those level of reductions last year, what do you think is going to happen in the upcoming years when they lose those potentially tens of billions of dollars in federal revenue that are projected as part of this bill?
All of that adds up to even more exciting news. So the workforce and access to care. So these are the two things now that really make you fearful as this continues to live down the hill. So rippling, like these deeper Medicaid cuts, what do you see happening with workforce stability, recruitment, retention at Magic 8 Ball? Where is this going with workforce retention and recruitment?
Oh, it's a tough one. I would love to have much better news and be singing happy songs with you, as opposed to walking through these issues after issues after issues. But it's a tough time in this program, and I anticipate the importance of these services will only continue to increase as the challenges we face also grow. In terms of workforce, there's a couple things to consider. I didn't mention this earlier because I wanted to save it for the workforce conversation, but a lot of the things that we were talking about around community engagement requirements apply to the workforce too. States set the budgets and essentially by default determine what individuals earn to deliver these services. And states have set payment rates at a level where many of the home care workers are enrolled in Medicaid themselves. And these individuals are enrolled often through that Affordable Care Act expansion. Individuals receiving services qualify for the exemptions. Individuals delivering services may not. And the argument is, and should be, well, these individuals are delivering services. They're paid by Medicaid. They're working. They meet that community engagement requirement. The states should be able to identify individuals that they are paying to do work and say, well, you meet the community engagement requirements. We know that because we're paying you to do a job. So we know you're employed. And that's another one of our big asks to CMS is make sure that those data sources are utilized in a way that minimizes the burden on workers, because we cannot place more strain on the workforce than there already is. Let me give you a specific example, Mike. I'm sure you guys at Beata and Hearts for Home Care are intricately familiar with electronic visit verification and all the fun aspects associated with that. If the state has EVV data that shows when a worker is checking in and checking out on a shift by shift basis, shouldn't they know right then and there if that worker meets 80 hours a week or 80 hours a month?
Should.
They should. So CMS needs to be very clear and tell states, you have this data, use it. And that's a big one of our asks to reduce the burden on the workforce in the ways that we can. Shifting from the community engagement requirements to the broader issue that you talked about, at the end of the day, I don't think anyone is out there saying that this workforce is fairly compensated. We in the industry fully recognize that these workers should be paid more, deserve more. And I think that, as I mentioned earlier, it's so much driven by state decisions and how states fund the services that it's impossible to look at the crystal ball for the next 10 years and that $900 billion projected reduction and not be fearful for further erosion of compensation to this workforce, whether it be just flat pay that doesn't go up even though costs are going up. I ask you, the listener, like, what does your budget look like at your home over the past 18, 24 months? It's not a political issue. It's just a cost of living issue. And if states don't raise their rates to accommodate for that inflationary pressure at the workforce level, those workers are going to get squeezed. And I think that that's the first thing we'll see. The first thing we'll see will not be straight cuts. It'll be flat funding. Then we'll see potential reductions. And then the reductions, create all sorts of challenges, whether it gets passed through to the worker or whether the company has to try and absorb it administratively. Either way, there are huge challenges associated with that. If you're a company, generally speaking, you don't have a huge margin in a Medicaid business. You just don't. Medicaid is high volume, low margin. So if you're getting squeezed and you're trying to protect your workers from further reductions, you're taking that in a very low margin environment to begin with. I was actually looking at some data earlier today from the Department of Labor. And the Department of Labor, in some of their regulations that they've issued in 2013, they estimated that there were a little over 80,000 providers of what they call home health care services and services for elderly and people with disabilities. In 2025, they estimated that there were a little over 60,000 people. 60,000 employers, companies. So that's over a 25% reduction in a 10-year period. And I don't think you can look at the environment and the way that we as a country have decided we're going to pay for these services and think that it's rational or acceptable. There's a reason that there are waiting lists. There's a reason that there's a lot of unmet care needs around the country. And there's a reason that the number of providers is declining. And it all comes down to the choices that are made in Washington, D.C. and in state capitals around the country.
A lot of mention of the word state. You said the state a few times. So states are gaining expanded flexibility over the coverage. How might that influence coverage decisions related to these home health services?
Absolutely. The way I've been talking about this is as it relates to Medicaid, a lot of the federal policymaking is done for the time being. They passed their big legislation last year in July. I don't anticipate any huge movement in Medicaid moving forward, at least in the next year or two. I think that the big cuts have been made. I don't think Congress has the appetite to go back and revisit any of these right now. So because of that, with federal policymaking done, it becomes a state by state implementation question now. We've gone from one legislature making decisions to now 56 when you include DC and the territories. And there are going to be 56 different choices that are made around the country. And honestly, there are going to be more than 56 because there are different programs and different home care programs within each state. And each of those state home care programs, the distinct waivers or personal care options or community first choice programs, are going to have distinct and unique decisions associated with them. So I anticipate there are going to be several hundred different decisions made around the country. And that will create a lot of challenges. It will create a lot of confusion. It's going to create a lot of work for us at the advocacy level and at the policy level to kind of understand and parse out not just what are the individual changes, but what are the aggregate impacts of this statewide or nationwide. What do I think at a big level? I think you will see some states really try to preserve services for individuals. And when they do that, they'll focus on maintaining eligibility and trying to limit the cuts to the number of hours or the types of services included in Medicaid. But think back to those three criteria I talked about earlier. If you try your best to preserve the first two, the only one left for meeting your budgetary targets is provider rates. As I said, I don't think any state is going to concentrate all of their efforts in any one of the three. But if you try to limit impact on options 1 and 2, then you have a larger impact on option 3. I think some other states will try to maintain some of the payment levels that we've seen a lot of effort over the past couple of years, particularly post-COVID, to have increased funding and increased funding that specifically flows directly to the workers as part of these home care programs. We've seen that a lot, whether it be through bonuses or pass-through requirements or other sorts of things. I think some states will really try to focus on maintaining those levels. But if they have budgetary targets to meet, then if they're really focused on maintaining the flow of funding to workers, you might see greater strain put on the waiting lists or fewer individuals receiving services or a limitation on the number of services that each individual can receive. Those are the key things I'm looking for moving forward, is starting to understand which bucket each of those states fall into. Are they going to preserve services? Are they going to preserve eligibility? Or are they going to preserve payments? And I think that those of us watching the Medicaid system, that's kind of like a good framework to approach the state decisions from, to kind of understand where their priorities are focused.
So, I mean, I scratch my head listening to all these answers. I'm sure everyone listening is also scratching their head and staring at their phone or their computer as well. Can I be naive, or is there something positive to take away from HR1 and the impact on Medicaid?
I think that there are a few positive things, actually.
All right.
Number one, I've talked about this a lot, and I don't want to be repetitive, but I do think it's worth stressing.
Yeah.
Every single policymaker, whether they were on the Democratic side of the aisle opposing HR1 or on the Republican side of the aisle in support of HR1, all of them repeatedly and adamantly expressed their support for long-term services and supports, for in-home care for older adults and people with disabilities as a crucial population in Medicaid that they wanted to support. Even while advancing policies that reduced Medicaid funding, congressional Republicans stressed that their view was they were strengthening Medicaid for older adults, people with disabilities, and other what they called core populations by placing these new restrictions on the Affordable Care Act expansion that, the policy debate around was really, are those individuals appropriately served through the Medicaid program, or should Medicaid be more targeted to the groups we're talking about? So there's a positive there in saying that there is bipartisan support for the services we provide and the individuals we support. The other thing is, there are continued pushes for home care. The overall federal policy zeitgeist, for lack of a better word, is towards in-home care. And, you can make the argument a lot of different ways, whether it's preferred by individuals, it's less costly than institutional care, it has better outcomes. There are a lot of positives we can point to in support of our services, and those resonate. And those resonate at the federal level, they resonate at the state houses. And when we're talking about states that are looking to revamp their services or try and manage their budgets, home and community-based services do represent an attractive option as states continue to look at their array of services and, are individuals appropriately served in high-cost institutional settings. I think deinstitutionalization has been proven, not just through theory, but through actual practice and research and outcomes, that the same individual who was served in a nursing home costs less, is happier, and has better outcomes in the community. And we see that through the money follows the person evaluations. We see that through independent researchers. And that's something for us to point to that is a positive.
Looking forward. Now let's look forward. Let's end on mobilization and activation. So how could organizations like National Alliance for Care at Home and other state advocacy organizations, Hearts for Home Care, whomever, what could they do to influence implementation and safeguard these future home care services?
Yeah, there's a lot to consider here. The first is we have a huge network. We have a huge network of individuals who are employed by home care providers who deliver care. We have a huge network of individuals who receive care. And all of these people have a voice and have a role in the political process that I frankly think is underutilized. I know that we as an organization have worked to try and expand our network and our ability to support those individuals to make sure their voices are heard. I know you guys have done a lot of work on that with your employees and client base. And I think that if our broader industry and community can truly make their voices heard, that's where the power comes. The other is that the beneficiary advocacy groups are going to be strong allies in this. We don't always see eye to eye on the best solutions, but I think especially in this upcoming period where we are all going to be, frankly, fighting to preserve and maintain home care services, they're absolutely going to be on the same team as us. And we should leverage those relationships and make sure that whether it's older adult advocacy groups or advocates for individuals with disabilities, labor organizations, all of those groups are going to be trying to preserve Medicaid funding and Medicaid services at the state level. And we can collaborate with them and really find ways that we can all support each other.
Love it. And I am sure I will see you on the steps of Capitol Hill sometime soon, advocating on behalf and making our voices heard on behalf of those clients and field staff to ensure that they have access to care.
That is
Damon.
one of our core goals at the Alliance, and we know you guys at Hearts for Home Care do the same thing. I'm sure our paths will cross.
Absolutely. Damon, thank you very much. Our listeners are really going to appreciate all the answers and the conversation we just had. And look forward to seeing you soon. Have a great day.